think he's out staying out in San Diego with the wife now. 712, good morning. It's the Link of the Breeze, 93.9. Let's just jump right into our KUAM News Zoom room where we have standing by Dr. Felix Cabrera of the Physicians Advisory Group. Good morning, Doc.
Good morning, Chris. Good morning, Bree. Good morning, Jason.
Good morning.
So we know we have the meeting tonight, but if we could just, and I don't know if you have any additional information on the 21st COVID-related fatality, but if you do, is there anything you can tell us, Doc?
No, I don't have any further information than what was just released, but, deepest condolences to the family and friends and to all those that we've lost so far to COVID-related deaths.
Mm-hmm.
What do you make of this increase since Friday? I mean, the deaths have, and this is something that the docs on the PAG had warned us about. They said, hey, when we went to this PCOR 1 lockdown, hospitalizations are going to rise. They continue to rise. GMH no longer accepting non-COVID ICU patients, and the deaths are so tragic. They just keep coming.
Yeah, and unfortunately, they're going to continue to keep coming, so I think, none of this is much of a surprise. And, we're getting better. The world is getting better at understanding COVID over the past 6 months. But one of the key things that we absolutely have to keep in mind is the lag. The lag is real when it comes to cases. So when we identify cases, and then when we start seeing spikes in cases, and then later 1 to 2 weeks, spikes in hospitalization, and then within 1 or 2 weeks, spike in ICU, and then spikes in deaths. So it goes in that progressive order, varying days that you can have between. But if we've been following the situation reports and the JIC, you can see that actually in terms of our daily new cases, now we follow them on a 7-day rolling average. So we look at the past 7 days. That kind of brings down the noise in the variability that we have for different factors, like all the different labs that are running tests. But if you look at the 7-day rolling average, we've had about almost 14 days of a decrease in daily new cases on a 7-day rolling average. That's extremely important for us to recognize, because what that tells us is that what we're doing is working. It's working, okay? And so that, it's not one of those things where you jump out of an airplane and the parachute works. And then you say, okay, it's working, I'm slowing down. And then you just release the parachute. No, we gotta land safely. And so that's part of what we have to understand here. And the governor will make a decision about PCOR 1, and we'll discuss that during our 8:30 meeting. And we'll probably discuss it more in detail. But because we're seeing that, we haven't fully seen the peak in the hospitalizations yet, even though we've seen this, what hopefully is the peak in new cases. And with that peak in hospitalizations, with it being delayed, what's making it more likely that it's, so right now, the hospitalization looks like it may have hit a peak, and we were predicting that it might have happened on September 4. And it looks like that's what it was, because the total island-wide hospitalization for COVID was about 60 on that day. And then every day it's been below 60 in the 50s. But we're kind of in a plateau over the past several days now, for almost a week. And so that's the major contributing factor is the rise in ICU cases. And so that's the key thing that we have to understand. And then with that, obviously we've had our deaths, but because we just recently seen the rise in ICU cases over the past week or two, that unfortunately more deaths are expected because of that.
Doc, so when we talk about these triggers that we talk about here on the show, triggers to move us in between PCORs, one of the key ones is the hospitalizations, but then the other one is the testing positivity rate and positive cases. Contact tracing. So I feel like when we talked to Public Health yesterday, they kind of had a better grip on the contact tracing. So with the triggers, different triggers that we have, and I know you guys advise the governor, but it's ultimately her decision. Do you think the PAG is in a position to advise easing of any of these PCOR 1 restrictions, or even a move from PCOR 1 to PCOR 2, even though the hospitalizations are, I would think, not in the stage where we can ease up? Because they seem to be like, if you look at the different triggers, the hospitalizations is probably the worst one, right?
Yeah, and so the key part is that if you remember the exact triggers, it was 14 days of decrease in daily new cases, and ideally below 5. We're at 30 something right now, still. Our test positivity rate also, we want that below 3, and then in terms of the doubling rate, that's another thing that we've been tracking, of course, real closely, and that's the number of days it takes for us to double our numbers of COVID-19 cases. And right now we are at, so our worst was 10 days. It only took us 10 days back in the end of August to double our numbers. Now we're at 21 days. So that's a big improvement. We want to be above 30 in that sense. So right now we're in the process of revamping the triggers, because this is an evolving thing, and we're learning from what we need to do to improve the triggers to inform a decision for the governor. And so the PAG is working that. Dr. Ricky Hernandez is doing that as well in terms of helping us design that. But I think it's pretty clear when you start looking at the triggers that we had placed from the past that we haven't met that to go into peak or 2.
Yeah.
And so, but it's not as simple as just saying, okay, are we going to stay in peak or 1? It's more, we want a more surgical approach to this in terms of if there's going to be a change, we may still stay in peak or 1, but what are the different changes that may happen within that? And so I think that's important, and we're focusing on, there's been discussions about low risk versus high risk, services, and how we might want to, splice that out and have a different level. So that's being worked on.
Doc, so Gene had put a comment here. Sorry, Gene. Yeah, the ability to conduct mass testing is one of the triggers to move between PCORs. How would you address that, Doc? Because I know there was a huge shift because, and talking to the docs, part of it was because when they did the mass testing before, it yielded low positives. And so they opted to go for a more targeted testing approach. Because when they did the mass testing, recently the demand was so great that they just couldn't accommodate, and we all know this story. They couldn't accommodate the number of swabs that they got, and so there was a huge 2-week delay in getting those results. So, in your opinion, how key is the ability to conduct mass testing when we talk about it as a trigger to move from PCOR 1 to PCOR 2, or to otherwise ease up on any restrictions that we're currently under now?
Let me make no mistake in saying this, in that Guam is one of the areas in the country that leads in our ability to test, and we're extremely fortunate for that. And that's a combination of us being a territory that's just an island, that we get the same share some states as a whole get. We have the support of the private sector, and we have the support of the Department of Defense. And so because of that, we actually have a pretty good ability. So, yes, there are hiccups, and we expect to have hiccups, and we have to learn from that in terms of the mass testing. But right now, I'm counting 9 straight days of dropping test positivity rate. So it looks like we peaked around 11.8%, and then we're down to 8.2%. So our ability to test it right now is I don't think that's really a concern, in that we're doing, right now, technically, in a technical sense, you want to do more if your test positivity rate is high. But we're doing the other end of that, which is the lockdown, so to speak, the PCOR 1. And that's what brings things down so that the testing can match up. So the rate that we're dropping in our test positivity rate is extremely encouraging. And so we have to focus on that now. Will we do the same type of mass testing again? Probably not, because we learned from that. But also we have to understand that part of the monies given to Department of Public Health's lab is that there has to be an ability to test 2% of the population. So there has to be a portion of that is mass testing in order to meet those requirements for that program. So so you're going to see a mix.
I'm sorry, did you say we were going to change the 14-day period to a 9-day period?
No. What I was saying in the 9 days is I'm just looking right now at our test positivity rate and the trend that we've had so far and that over the past 9 days we've had a drop in our test positivity rate. So I was just mentioning that that's not about what we're gonna necessarily do. I think ideally we want to continue this and see this all the way down below 3%. But we passed the first hurdle, which was getting below 10%. When you're above 10%, the pandemic's out of control. Below 10%, you're starting to get control. Below 5%, you're doing pretty good, and then below 3%, you're very well controlled. And so we were below 3% for majority of the summer, and so I have a lot of faith that we'll get back to that.
And so is that what you guys are going to be talking about tonight? Changing these triggers?
Yeah, I think that's going to be a big part of the conversation, and we'll continue to work on that. There's different angles that people are making suggestions, and we'll review that. We're going to compare with other states also. I know California has a pretty good plan, but the key thing is the states that have done this successfully, New York being the best example. They've done it extremely slowly, and there was no rush. And I think that's the key point that everybody has to accept, and let's set that expectation now that that we have to be patient through this process and let it be a slow process. And so in that same time, which is probably difficult to sustain, but we have to really keep our eye on the ball, and that's protecting the vulnerable. Okay, I know we say that a lot, but I cannot emphasize that any more than I am right now. In that it's not just that you just say, oh yeah, I won't, if I'm sick, I won't go see my grandma or something like that. But even within the household, it's very important. We're seeing a significant spike in hemodialysis patients becoming COVID-19 positive. That's extremely concerning. And people, we say comorbidities, but let me be very clear so that everyone understands. We're talking about people with diabetes, with hypertension, who are on dialysis, with kidney failure, who have cancer. But what we're seeing, especially in younger people, is morbid obesity with the combination of diabetes. That too that makes you really high risk. And so we have to be very conscious of that. And morbid obesity is, again, it's not an opinion, it's a diagnosis. So people, let's get over being offended if your doctor calls you obese, because it's a diagnosis. Obesity means your body mass index is above 30, and morbid obesity means it's above 45. And probably at least 1/3 of the island meets the obesity diagnosis.
Doc, can you kind of go into that? When we asked Dr. Maglotny this the other day, but when people talk about these COVID-19 patients with the pre-existing comorbidities, there are some people who say like, oh, they would have died anyway, or oh, did they really die of COVID-19 because they had diabetes? And so there are people who are trying to dispute whether or not these deaths are in fact caused by or related to COVID-19. So just from the medical standpoint, and I know we've had this conversation before, can you just explain again, for the record, what happens when someone with a pre-existing condition contracts COVID-19?
Okay. Let me try and say it very simply, and then I'll follow up with an analogy. And the analogy that Chris, you and I had in conversation, off air, is that first of all, these comorbidities are already killing us. They're just doing it very slowly. COVID ramps that up. It speeds up that whole process. I mean, really speeds up from something that might take years or even a decade to a matter of a week to 2 weeks. So that's first thing that we have to understand. But the thing with what's so disheartening is when people say, oh, they're gonna die anyway. What does that mean? I mean, who has the gall to say that about a human life, that especially somebody who's who is a productive member of society, and many of these people who have passed from COVID-related deaths are productive members of society and have loved ones and was still having the ability to have a quality life. So this is the analogy. So in a lot of these COVID-related deaths, we can never be 100% sure that it was a specific that COVID by itself was the one that caused the death, because COVID affects the whole body. But that analogy that I'm going to share here is, so let's say someone has end-stage cancer, stage 4, metastatic cancer, and they go on hospice, which is end-of-life care. And so, but let's say an event happened, somebody broke into the house and shot them in the leg, okay? And they started to lose blood, and they couldn't survive that blood loss because they were such in a weak condition. So did that person die of cancer, or did that person die of a gunshot wound? The law is going to say that person died of a gunshot wound, and we'll prosecute that person who shot the victim, for murder. So why is that any different with COVID? I mean, it seems very clear when it comes to that analogy, because we can see a bullet, we can see the wound, but we can't see COVID. So that's a very powerful thing that we have to really understand, and that people survive gunshot wounds, but me and you, Chris, we may be able to survive that same blood loss, but somebody who's weaker is just not going to. And so that's the thing that we have to really understand. We have to respect everybody's different, varying ability to handle different challenges, and I think that that's something that is very important. I hope people start respecting that, because in the end, when we respect that fact, then we respect each other to a different degree that really helps protect our entire community.
I wanted to ask and talk about dialysis patients. Is there any reason to suspect that some of these dialysis patients are possibly catching COVID at these dialysis centers?
I think if I recall what they're in the cluster studies, that it's variable, that it's not just coming from one specific place, and that I think the rate that they're being infected is what you see amongst the typical vulnerable population anyway. So it's not like there's a one dialysis center where it's a major outbreak there. So it's pretty spread around. So it's not like it's related to that. But again, we've always identified them on the top. I mean, I remember very early in this pandemic when we were looking at what was the potential for how dangerous this was going to be. There was even a thought of offering every dialysis patient, every comorbidity patient with significant comorbidities, a room at Leo Palace. And doing something like that to protect them. We didn't know if that was going to be effective. We didn't know, is that something that's even makes sense right now? Probably not, because I think the family component is important, but it's also what the risk is as well. So we can and most people probably won't take that offer because they want to be at home, even if it's in a nice, comfortable setting. But in the end, we can make our loved ones comfortable at home, but we still have to, do our best to protect them. That means, if possible, using separate bathrooms and separate areas of the house, definitely a bedroom for themselves, and consistent sanitizing and wearing a mask within the house.
And Doc, so when we talked to Lillian, so now if you test positive for COVID and you're a dialysis patient, it's automatic 14 days in the hospital. And this measure was done obviously to mitigate these positives from going to dialysis centers out here, right?
Yeah, it's really tough, Chris. It's such a tough position right now because it puts tremendous stress on GMH, and it's extremely difficult for them to have to handle that. But at the same time, the potential for an actual major outbreak in one of these dialysis centers is it would be just awful. So we have to, so because of that, I know there's discussions about having a dedicated, one of the dialysis centers to be dedicated to those who are COVID positive, but are well enough to not need to be hospitalized and just need their dialysis. So that's, I know there's some discussion with that. So, as you know, GMH right now, I wanted to just be sure I slipped a few of these facts in because it's important for us to understand that, when you look at all the patients that are hospitalized for COVID-19 here on Guam, the percentage of those who are hospitalized that are in the ICU is about 20 some percent, and that's about matches what the nation is for COVID. And so actually, I have the actual number right here. I'll put in a second. So it's a 22% that we're seeing. The nation is about 20%, but those who are in the ICU that need a ventilator to be on who need to be on a breathing machine. The US average is about 28%. Guam, over the past 30 days, 58%. In the past 7 days, the past week, 86%. That means that our people are extremely sick when they do come to GMH, and when they are admitted to the ICU, they're extremely sick. And so much sicker than most of the typical COVID ICU patient in the country. And so that's something that we really have to understand. Everything we do is about protecting GMH, protecting the ability for GMH to take care of these patients. GRMC is rallied to do everything it can to support this. They're dealing with the non-COVID. Chris, can you imagine if COVID-19, if it hit Guam 5 years ago? GRMC didn't exist 5 years ago. And right now, they take care of a significant majority of the adult inpatients. And so I can't even imagine how, what kind of state we would be if GMH was the only, public hospital or non-military hospital on the island. And so, we have to be thankful for what we have. We have to be grateful. And I think that's important. We have to count our blessings, and we have to count our blessings that technology has been a big advantage. Thank you so much for having the GNA's, bid with, especially with Paula. I think Paula's done a tremendous job at GMH, and she's really elevated the informatics part of healthcare. We work with her closely. I worked with her when she was a telemetry nurse and at GMH, and so that's good to give all these different perspectives.
Do you have any update on the skilled nursing unit? Is that finally open? I know that we got the FEMA nurses here, and then we got the 6 combat medics from the Guam National Guard over at the Guam Memorial Hospital. Is there any update?
Yeah, I don't have specific updates for the SNU. I'm sorry.
Okay.
Doc, we had a comment here, and it kind of goes to the targeted testing. Maybe dialysis patients should all be tested. Michael comments, I'm all for that, as my dad is a dialysis patient, and I worry about him every day. So we've done it before where we did the targeted testing of the elderly, the people with the symptoms, the frontliners. Do you think that we should do targeted testing for dialysis patients?
I think that that's definitely, and the PAG, I think the PAG and the state surgeon cell, I think have been consistent in saying that needs to be a priority. And they are doing that, but not in necessarily a systematic fashion, in that they're testing, as they come in and they see them, and they have an extremely low threshold to test. The question that comes up is how frequent to test them when they don't have symptoms, and that's where I think it gets even more difficult to answer that question. That same question can be posed for even healthcare workers, right? Even if we test all the healthcare workers on the island, like how frequent should we be testing them? And what does that do in terms of the equal distribution of that resource?
Okay. Anything else you guys going to be talking about tonight during the PAG meeting?
Yeah, and we're probably going to talk about the quarantine situation, I'm sure. I don't want people to mistake discussions for decisions.
Mm-hmm.
And so it's important that we have these discussions way early, even before we think we're ready to make any changes, because it takes a lot of time to figure these things out. So the different testing protocols, I got to tell you, Saipan has the CNMI has a very strict and very effective quarantine process. And in discussions with them, it's probably going to mirror something similar to that. It's easier for them to implement that because of their size and their actual testing ability, but also that they don't get the same number of flights in, that Guam does. And so that's a very big difference. So for us to operationalize a similar protocol that the CNMI has, that's going to be, it's exponentially more difficult. But it's a model that we know works. And Saipan, in the CNMI, their healthcare system is way more fragile than Guam, and we're already fragile. So they have to be extremely more strict because there's, can you imagine if a similar spike like this happened there, and how tragic that would be. And, it really hurts my heart to even think about that.
Well, Doc, any secrets you want to tell us about the press conference today?
I think I spit everything I know at this point. So,
all right, you got that Link Truth Serum. So that's 10 o'clock, right? And they're gonna
10 o'clock.
So from what it's going to be kind of the official unveiling of the Sarah app. And do you anticipate any other?
The Sarah app or the Guam COVID? The Guam COVID alert app.
Yeah, the COVID thing. I don't know. Do you
Go ahead. Can I make a very important point?
Sure.
And so. That press conference is probably going to be very specific to that, but it's the Guam COVID alert. Mm-hmm. So the Guam COVID alert is for everyone, the entire island, okay? And so Sarah alert is for those who are in quarantine and isolation. So let's be very clear and make sure we use the right language, because when we talk about apps and technologies,
I got to go sit in the corner now or what?
So the key thing is that with this Guam COVID alert is that the only way it's successful if it penetrates, up to a vast majority of the people on the island. We know that that there's a limited number of people who actually have smart devices, but they have to download the app. They have to open the app. They have to run through the things to ensure it sets up, and it's just mostly just saying yes, yes, yes. And then that's it. And it's one of those things that protects your privacy, but it lets you know, and it makes the contact tracing. If you did contact somebody who was COVID positive that you don't even know about, it alerts you quickly so you can get tested and cared for quickly and potentially go into isolation. So it's a tool. It's not going to be the end all be all, but it's a major tool. But it's only going to work if we get the whole island to use it. So I don't know, maybe there needs to be more incentive, like, you cannot enter Ross unless you have you have the app on your phone, something like that. And so, but that's where the private business community can maybe step in and really help foster something like that. I think in China there was like, you can't get on the subway if you didn't have their app, downloaded.
Yeah, that's China though.
Yeah, exactly. Yeah. So that's the government saying that about the subway, but the business community can say that you see it everywhere here. You can't enter without a face mask, and that's the business community.
How about you can't get your tax refund unless you have the app? We'll see what Daphne thinks about that. Doc, last question here. A comment from Lauren chiming in on our Facebook Live feed. Sounds like it's going to be a while longer to move to PCOR 2. Everyone's hair will look so depressing. As a hairstylist, I believe my field is essential for everyone's personal and mental well-being. Agree or disagree, Doc?
I just want the pet groomers to open up soon so I can get my haircut.
Right. The pet groomer, at least, so essential. We'll get a twofer. Cut the dog, cut the chicken, and do the owner. Yeah, Doc, I know. Trust me. Okay. Thanks, Doc. We'll see you later.
Thank you, everybody. Thanks for your
okay.
Be safe.
7:40. Hey, we got to take a quick break. Come back with Daphne Shimizu of the Department of Rev and Tax at 7:41. Is the link on the breeze 93.9.